Welcome back to the deep dive. Today we are shrinking down to what might be the most critical, most time-sensitive frontier of modern medicine. We're talking about reconstructive microsurgery. So if you're following the incredible work that plastic and reconstructive surgeons do, moving these free flaps of tissue or muscle or skin from one part of the body to another, the success of that huge operation hangs on one tiny detail: reconnecting the blood supply.
And we're talking about vessels that are often barely a millimeter or two wide. It's just incredible. Success here isn't just about making it stick. It's high stakes, microscopic plumbing.
Exactly. The procedure is called microvascular anastomosis, and for a long, long time, it's been the main bottleneck in these, 8, 10, even 12-hour procedures. The connection itself is so tedious, it demands this intense focus, and it just eats up valuable OR time. So we dove into a source that really challenged that status quo. It's a 2006 study from the Annals of Plastic Surgery. This team introduced a pretty audacious new technique, a kind of super efficient shortcut called everversion with 3 horizontal mattress sutures.
Just 3 sutures. It sounds almost impossible.
Right. And our listener is intensely focused on surgical efficiency. So our mission today is to figure out if this 3-stitch method can really beat the old benchmark. We need to unpack how it stacks up against the classic technique in terms of, speed, success rate, and this is the crucial part: what microscopic damage might be traded for those precious minutes. So let's start by defining that benchmark. What was the gold standard?
It's hard to overstate how critical this moment in the surgery is. When we talk about the classic end-to-end anastomosis, the benchmark, we're talking about using many individual interrupted sutures. A surgeon would typically place between, say, 8 and 10 separate stitches.
8 to 10.
8 to 10, all just to get that perfect alignment and a leak-proof seal on 2 cut vessel ends. It works. It's precise. It's incredibly reliable. That's why they call it the gold standard. But that reliability came at a really high cost: time.
And when we talk about time, it's not just about the surgeon's patience, is it? We're talking big financial implications and, more importantly, that clock ticking on the transfer tissue. Why were researchers so desperate to shave minutes off?
That is the crux of the issue. A long surgery means prolonged anesthesia for the patient, which has its own risks. It means exponentially higher operating room costs. But for that piece of tissue, for the flap, those minutes are absolutely vital. It has to have blood flowing through it quickly to prevent ischemia.
Ischemia, the lack of oxygen.
Exactly.
Yeah.
The thing that leads to cell death. Shaving 5, 10, even 15 minutes off that connection can be the difference between a successful graft and one that just fails.
So the drive for innovation had a few goals then.
Right. 3 main technical goals. First, obviously, reduce the time. Second, use less foreign suture material, which can cause inflammation or clotting. And third, just inflict less trauma on the very delicate vessel wall during the stitching itself.
And I'm guessing this wasn't the first attempt to fix the problem. It sounds like surgeons have been trying to cheat time for decades. What else did they try?
Oh, absolutely. This is a highly contested area. The source shows a whole landscape of alternatives. Some tried using sleeves or cuffs to slide the vessels over, but those often required specialized equipment, added a lot of complexity. Others tried continuous sutures, one long running stitch. It's faster than interrupted ones, but it has a high risk of what they call a pursing string effect. It can cinch the vessel closed.
And that would restrict flow, which completely defeats the purpose.
Precisely. And then there were the glues. Fibrin glue, cyanoacrylate. They eliminate the stitching trauma, sure, but they often just lacked the strength to hold up against arterial pressure. Or they'd cause their own inflammatory problems. So the classic mechanical stitch, that 8 to 10 stitch protocol, it just remained the reliable default, even though it was so slow.
Okay, so enter this 2006 study, offering a purely mechanical but a radically different way to do it. Let's get into how they tested this innovation. The researchers were focused on proving it could work at a scale where precision is just everything. So the study was done on 30 Wistar albino rats looking at the femoral artery. The whole thing was under a microscope at 16x magnification. That tells you the level of detail we're talking about.
It's painstaking work.
So they made 2 groups, 15 animals each. Group 1 was the control. They got the classic interrupted anastomosis, which took an average of 9 sutures. Group 2, the experimental group, got the new technique. Just 3 horizontal mattress sutures. A real head-to-head competition.
And the genius here, I think, is that the innovation wasn't just the stitch count. It was a complete redesign of the vessel ends themselves. They didn't just try to put 3 stitches where 9 used to be. They fundamentally changed the shape of the junction.
Okay, let's unpack that because this is where it gets really interesting for anyone learning surgical technique. So I'm picturing a surgeon prepping the two vessel ends. Walk us through how they create this new connection point.
So first, they prep the vessel. They excise the adventitia, that's the wispy outermost layer. But then comes the key step. Instead of just joining 2 flat circles, the surgeon makes 2 full-thickness incisions on the anterior wall. They're very short, just the length of the vessel's radius, and they're spaced precisely 120 degrees apart.
120 degrees. Why that specific angle?
That angle creates 2 opposing pairs of, think of them as rectangular vascular flaps, almost like a little star pattern. This design lets the surgeon connect the corresponding flaps using a horizontal mattress suture near the base of each flap. So that's 2 stitches done, securing the whole front half.
And then what? They flip it over to get to the back?
Exactly. The vessel approximator, the clamp, is rotated 180 degrees. They make a 3rd incision on the back, midway between the first 2, which forms more flaps. And a 3rd horizontal mattress suture completes the whole thing. But the crucial design insight, and you touched on this, is that the horizontal mattress suture keeps the knot and the bulk of the material outside the vessel lumen.
That's the master stroke. With the old method, every single one of those 9 stitches goes through the wall and dips into the bloodstream. It's putting a foreign body right in the flow path.
A major clotting risk.
A huge clotting risk.
So by keeping the suture external, they minimize that contact, potentially reducing the chance of a clot, and at the same time, they dramatically speed up the process, which, leads us right to the data.
Right. It sounds great in theory, but did they actually save time? And if they did, what was the price? Let's start with the race against the clock.
The time savings were substantial. In the classic control group, the one that needed 9 sutures, the mean time for the anastomosis was 20.2 minutes.
Over 20 minutes for one single connection.
For one connection, yes. But when they used the new experimental technique, with only 3 sutures, the mean time dropped to 15.2 minutes. That's a clear 5-minute saving on average.
A 5-minute saving in an OR where costs are thousands per hour and a flap's life is on the line? That's huge. Was this just a fluke or was it mathematically proven?
It was statistically confirmed. The difference was highly significant with a p-value of less than 0.01. So what that means for you is that the researchers were over 99% confident that the time saving was real, that it was due to the technique and not just random chance. It is objectively faster.
Okay, faster is great, but speed is worthless if it doesn't work. How did they measure success?
They measured patency. Basically, as blood flowing through the repair, they checked immediately, then at 1 hour, and then again 3 weeks later.
And what were the short-term results?
Immediate and 1-hour patency rates were perfect. 100% for both groups. Right off the table, everything was flowing just fine. The real test, though, is long-term success. So that 3-week mark,
And what did they find?
at 21 days, the classic group, the gold standard, it maintained its perfect record, 100% patency. The fast new 3-suture technique, however, its patency rate was 93.4%.
Okay, there it is. 100% versus 93.4%. That's where the real discussion for a surgeon begins, right?
Yeah.
You save 5 minutes, but you lose a small percentage of successful outcomes. Was that drop actually meaningful statistically?
It's a critical question, and this is where you have to understand the statistics. The researchers found that the difference in those patency rates was not statistically significant. The p-value was greater than 0.05. So in practical terms, while 100% is always the goal, the data shows you can't confidently say that the new technique caused a higher rate of failure. Clinically, they were comparable, even with that lower number.
So you have a statistically significant gain in time, paired with a statistically non-significant drop in success. That's a powerful argument for efficiency. But to really understand the trade-off, we have to look deeper inside the vessel itself. So let's go from the operating table to the microscope and look at the histopathology, the tissue damage. What was the cellular cost of those 3 stitches in 5 saved minutes? What did the staining show?
This is where the story gets a lot more nuanced, and where the new technique showed its complexity. The microscopic examination showed that the 3-suture method caused increased intimal and medial damage compared to the classic one.
Okay, the intima, that's the super smooth inner lining of the vessel, right?
Yeah.
The part that keeps platelets from sticking and forming a clot. Damage there sounds...
It's a serious problem. And they cataloged specific issues in the experimental group. One sample had a formed thrombus, a clot. 3 of them showed medial calcification, which is a hardening of the vessel wall. And overall, they noted more inflammation and granulation tissue in 5 of the samples. Essentially, the vessel wall just reacted much more intensely to this type of repair.
So it sounds like the mechanical action of making those three little flaps and pulling them together was just more traumatic than carefully lining up two flat ends.
That's the most likely explanation. The source suggests the damage could be from ischemia, a lack of oxygen, to the very tips of those little flaps they created. Or maybe the sutures were just pulled too tight. But, and this is a really interesting point, we have to connect this back to the functional benefit. The very action that causes this damage might also be an advantage.
How so?
By disrupting the circular musculature of the vessel wall with those cuts, you may actually be preventing vasospasm. That's the sudden, severe narrowing of the artery that can instantly shut off blood flow. So the design might be this really complex trade-off. It causes some tissue damage, but it might promote patency by physically stopping a spasm from happening.
That is a fascinating contradiction. The method that looks rougher under the microscope might actually be functionally smarter in a high-tension situation.
Yeah.
Okay, so if we weigh all of this, what are the big arguments for a surgeon to adopt this technique?
Well, number 1 is time. 15 minutes versus 20. Second, less material, just 3 stitches instead of 9 or 10. Third is that critical design point we mentioned, keeping the foreign material outside the blood flow path.
And you just brought up the potential prevention of vasospasm, which could be an immediate lifesaver for the flap. Plus, it's cheaper. Fewer resources used.
Exactly.
But no technique is perfect. If I'm a surgeon getting ready to try this, what are the red flags? What's the biggest demand on my skill?
The difficulty is all in the precision. The biggest challenge the researchers cited is making those 3 initial incisions perfectly evenly spaced and all the same length.
And if you mess that up?
If the flaps are misaligned, the consequences are severe. You drastically increase the risk of narrowing the lumen, which chokes off blood flow. And misalignment also leads to more bleeding and what they call hemodynamic turbulence right at the connection site.
Hemodynamic turbulence. So the blood flow gets all choppy right where you made the repair.
Which is a major precursor for a clot. You need that smooth laminar flow. And one last practical thing. This technique needs a little more vessel length to work with to create the flaps. In a situation where you're already short on vessel length, that could be a deal breaker.
So it sounds like a technique that trades complexity in the prep work, getting those 3 incisions just right for speed in the actual stitching. It demands a very specific kind of finesse, but the payoff is huge.
That's a perfect synthesis of it. We looked at this 3-suture aversion technique, a really bold, faster approach. It gave a statistically significant reduction in operating time, a crucial 5 minutes, while getting long-term patency rates that were statistically comparable to the old classic method.
And the study's final conclusion was pretty balanced. It basically said that as long as those critical steps are done flawlessly, this new technique is a viable, high-efficiency option. It successfully trades that minor drop in absolute patency for major gains in speed and material reduction. But this brings us right back to the heart of the matter for you, the learner. You have the benchmark, 100% patency of 3 weeks, less tissue damage, but takes 20 minutes. Then you have the innovation. It saves 5 minutes, causes more microscopic damage, but gives you a statistically comparable 93.4% patency rate. So for a surgeon in an 8-hour reconstructive procedure, where do you draw that line? At what point do you prioritize maximizing efficiency, saving those 5 minutes, to reduce anesthesia time and flap ischemia over, minimizing the likelihood of even a single bad outcome in a statistically non-significant area? When does fast become good enough? That's a trade-off worth mulling over long after this deep dive ends.